I think the thing that makes PRMA stand out among places that might offer breast reconstruction is the dedication we have to this one purpose, and that is breast reconstruction.
We focus on the patient. The patient comes first. We try to strive for the best possible overall quality care from the very first time they pick up the phone to call us to the time that they're done with all their reconstructive procedures.
PRMA, I feel, is the best place for breast reconstruction for a number of reasons. One is that we've been doing it for a long time, so we have a lot of experience. We've seen all kinds of patients and chest wall defects. We've mastered the evolution of the free tram flap to the deep flap or the DIEP flap.
Among us, I have the world's experts in flap surgeries.
I love the shared passion that we all have. It's selfless. And it's an endless passion.
Many patients are going through a very stressful time with the initial diagnosis of breast cancer, and certainly patients also are going through a stressful time if they're deciding to do a prophylactic mastectomy and nipple sparing.
The first line approach for breast reconstruction is what the patient wants. Having said that, each patient should be well informed. We have many patients that come to us and don't have a very good knowledge base of what the plastic surgery reconstructive options are. At PRMA Plastic Surgery, our philosophy is a forever reconstruction. What I mean by that is by using the patient's own tissue. It's a process that doesn't have to be repeated 5-10 years down the line, and that approach is with autologous tissue.
The most rewarding thing about being a plastic surgeon for me is helping my patients in their fight against breast cancer. I feel like it's my mission in life.
We've done a lot of plastic surgery in our careers, and we've worked on children, and we worked on cleft lip and palate, and reconstruction of many, many defects, head and neck, but breast cancer surgery and breast cancer reconstruction is particularly exciting and rewarding because the patients are going through one of the most difficult periods in their lives. Oftentimes they don't have any background in it, and we're able to navigate them through with the help of our team.
What I like most, and I think the guys in the group do as well, is that we get to help people through this depressing process of overcoming breast cancer. It's the silver lining, if you will. And we get to walk with the patients usually for at least a year through this process, and to see them go from their initial phase of bad news and crying and sadness to finally putting this behind them and sending them on their way is very rewarding.
Breast reconstruction patients are warriors. They have families, they have significant others, and to be in a position to help a patient through that, make them whole again, things like that are a cliche, but it's true. We really do feel like we're offering a positive note in an otherwise difficult time for patients.
So every single patient is unique. Everyone has their own experience, their own perspective of their disease, and it's inspiring to see the patient and see how they triumphantly deal with breast cancer.
I don't have one particular patient that sticks out in my mind because I've had so many that are just, they come to you, they've sometimes been told there's not a good option for breast reconstruction, or they're scared, they're going through a process that's very overwhelming, and they come to us and we can have a solution for them and help them in the small step, which is overcoming breast cancer.
I don't like the way patients come in and where they are when they come in, when they see us. Plastic surgery's typically associated with something you've always wanted to improve yourself and look and feel better about yourself, and patients come in and that's just not where they are. But I do like the transition, and I love the end, and I love it when they express what it means to them. That's a really big deal.
Yeah.
I love that.
The DIEP flap procedure is a method of breast reconstruction that was popularized not too long ago, in which the tissue from the lower tummy is taken to reconstruct the breast that has been removed after a mastectomy. DIEP stands for Deep Inferior Epigastric Perforator Flap. With the DIEP flap, only the skin, fatty tissue, and blood vessels are removed. The tissue is disconnected from the body and transplanted to the chest using microsurgery. The muscle that is in the lower abdomen, as well as the tissue that holds everything together, called fascia, are spared during this type of reconstruction. Therefore, only the tissue that is needed is what's utilized to reconstruct the breast, which allows the patient to maintain their core strength in their body in order to have a normal function postoperatively. Similar to the DIEP flap is the SIEA flap. SIEA stands for Superficial Inferior Epigastric Artery Flap. Lower tummy tissue is used to reconstruct a breast following mastectomy. Although the SIEA is similar to the DIEP, it is used less frequently since the arteries required are generally too small to sustain the flap in most patients. Sensation following mastectomy is very variable. When we are doing DIEP flap reconstruction, when we're looking for the blood vessels that are providing blood flow to the skin and fatty tissue, we also look for sensory nerves that are traveling with those small blood vessels. If we find those sensory nerves, we will dissect them. We will remove those sensory nerves also with the skin and fatty tissue that is utilized to reconstruct the breast. Once we move the tissue up to the breast, we reconnect those sensory nerves to the sensory nerves that are normally providing sensation to the normal breast to hopefully improve their sensation postoperatively. The feelings of the breast reconstruction results are usually very, very natural, usually a very warm, soft, and natural feeling of the breast, which is significantly different from other types of reconstruction. One of the things I tell my patients usually is that using the lower abdominal tissue, it very closely replicates the consistency of the breast tissue that is normally there. Therefore, using that part of the body, we're able to acquire or obtain the best and most natural possible outcome.
The Tug Flap is one of several tissue techniques that we use for breast reconstruction. The term tug, the initials TUG, stand for transverse upper gracilis flap. And that terminology speaks to the blood supply and the muscle group in this particular case that flap is based on. It is a method of reconstruction that takes tissue from the inner thigh area. It's a transplant, so we're going to move that tissue from the upper inner thigh up to the chest area. And we're going to graft this tissue into a reconstructed breast, just as we do with the DIEP flap. The scar placement for the tug is in the upper inner thigh. It's kind of a curved incision, and it's well hidden, even if you wore a typical pair of shorts or even a swimsuit. Alternative thigh flaps also include, one, the lateral thigh perforator flap, or the LTP flap, which uses tissue from the outer buttock and top of the outer thigh. Two, the profunda artery perforator flap, or PAP flap, which uses upper posterior thigh tissue just below the buttock crease. Three, the vertical upper gracilis flap, or VUG, which uses the tissue from the upper inner thigh. Finally, the anterolateral thigh flap, or ALT flap, uses the patient's tissue from the upper outer thigh. The benefits of the Tug Flap are that a patient gets a reconstruction using her own tissue. And in our practice at PRMA, we feel that's a great advantage to use the patient's own tissue for the reconstruction.
For patients that don't have abundance of tissue in their abdomen or they've had prior abdominal surgeries, the gap flap is a great option. The gap flap stands for gluteal artery perforator flap. It's based on the tissue from the buttocks. It's a tissue that's supplied by a small branch of a blood vessel that comes off an artery and vein near the buttock region. So when we transfer the gluteal flap from the buttock area to the chest to create a breast mound and ultimately shape a breast, we use our microsurgery techniques that we use for other types of flaps as well, and we spare the muscle and the nerves that give the buttocks muscle its blood supply and its nerve supply. When we design the flap, we can have it designed in two different ways depending on where your tissue abundance is located, either in the upper gluteal region or in the lower gluteal region. For the upper gluteal flap design, the scar is usually hidden in the underwear line in the upper portion of where an underwear or a bathing suit would sit. For the lower gluteal design, it is based on the lower gluteal crease area, also covered by the underwear or swimsuit line. It is technically possible to do a bilateral gap reconstruction. However, most plastic surgeons and microsurgeons do not recommend doing that all in one surgery procedure. It is a longer type procedure simply because of positioning during the surgery, and the majority of us have a consensus that the best utilization of the surgery and time in the operating room is to do one procedure at a time. When the gluteal flap is taken from either the upper or the lower buttock, it can have some contour irregularities. We try to do our best to minimize that by using our plastic surgery techniques and closing the wound in a way that can minimize the scarring and contour irregularities. Having said that, most patients do not find it to be a significant burden as far as the contour. The main benefit to the gap flap is using your own tissue. It's the same benefit as using other autologous tissue reconstructions such as the DIEP flap, the gracilis muscle-based flaps, or the Latissimus flap. So the benefit is you don't have to have an implant-based reconstruction. It's based on your own autologous tissue.
There are two main ways to do reconstruction. One way is with implants, and the other way is using your own tissue. There are four main places where we can take tissue to use for breast reconstruction. They're the abdomen, the back, which is the latissimus flap, the buttock, and inner thigh. The latissimus flap is probably the oldest or longest known of the tissue flaps. It's been around for probably almost 40 years. The latissimus muscle is a large triangular shaped muscle that covers most of the back. One end is in the axilla or armpit, and the other broad part connects along the spine. The surgery disconnects the broad area in the lower back. It's tunneled usually under the skin, kind of through the armpit and out to the chest to use the tissue either by itself or along with an implant for reconstruction. The patient's ability to function after a latissimus flap is really normal. There are so many other muscles that provide the same function as the latissimus muscle that we can borrow it for breast reconstruction and not result in any functional deficits. The recovery time after a latissimus flap surgery is going to vary patient to patient. Generally, I have patients reduce their activity for about 6 weeks to allow for healing. But after that, they can begin training or their activity back towards normal.
The most common method of reconstruction performed today uses implants. That's usually performed as a staged approach, meaning that more than one surgery is usually needed to get the final result. The first stage involves placement of a temporary implant called a tissue expander. That's more or less a spacer that we use to create the general shape of the breast and the rough approximate size that we want to achieve. The expander is placed at the same time as the mastectomy. That's called immediate reconstruction. Or it can also be placed at some point after the mastectomy, anytime later, in fact. That's called delayed reconstruction. The expander is placed either on top of the muscle or under the main chest muscle, the pec muscle. Most surgeons will place the expander under the muscle. And over time, the expander is inflated using salt water or saline to achieve the desired result. After completion of the whole expansion process, that's usually about 3 months, the patient goes back for a second procedure, again under a general anesthetic, and the expander is removed and the final implant is placed. And that's either a saline or a silicone implant based on the patient's preferences. Other procedures can also be performed at that second stage in conjunction with the tissue expander. The most common procedure is fat grafting or fat injections. And that's used to correct contour defects left behind from the mastectomy. The fat is injected under the skin and it improves the padding, the soft tissue padding over the final implant. So it decreases the chances of being able to see the waves in the implant shell, which is known as rippling. Some women are candidates for a single stage implant breast reconstruction. That's known as direct to implant or single stage or one step. The single stage and one step names are a little bit misleading. A lot of patients, unfortunately, will need more than one surgery still, even if they're having a direct-to-implant procedure. Again, the most common procedure performed secondarily with direct-to-implant is fat grafting, again, to achieve the best soft tissue coverage over the implant and the best cosmetic results. Most implant reconstructions are also performed in conjunction with alloderm or another form of acellular dermal matrix. That's usually a cadaveric product. It's essentially a biologic sheet that we use in conjunction with tissue expanders or direct-to-implant breast reconstruction. Unfortunately, there are many misconceptions about implant breast reconstruction. The biggest is that it's an opportunity to turn a horrible situation into the breast augmentation that the lady always wanted. That's a problem because it really leads to heightened expectations, and the results of implant breast reconstruction are very rarely as nice as cosmetic breast augmentation. The main difference between a lady having implant breast reconstruction and a cosmetic breast augmentation with implants is the amount of tissue that she has to cover the final implant. The main disadvantages of breast implants is that the reconstructed breast typically feels cold. There can be significant rippling that the patient can see through the skin. That's waves in the implant shell that look like ripples. Over time, the body creates scarring. A scar shell or capsule develops around the implant that causes hardening. And there's a much higher risk of needing further surgery because of implant-related problems. So even though we say that the implant is permanent, unfortunately, there's a high chance, a high likelihood that it won't be the final procedure that the patient has. The other big issue with implant reconstruction is what happens when a breast cancer patient needs radiation. Radiation and implants don't mix well. Plenty of plastic surgeons offer implants in radiated patients. It's a very acceptable approach, but the evidence is clear. The literature is full of studies that has shown repeatedly that implants don't do well with radiation, and the failure rate is very high. By failure, I mean the implants aren't working out and the patient needs something else done. Typically, failure means the implants have to be removed and something else has to be done. The failure rate with implants in a radiated patient is close to 1 in every 3 reconstructed breasts. That's a very high failure rate. So when it comes to radiation, really, there is no substitute for healthy tissue being used as the main source of reconstruction. The success rates are much higher, and the risk of needing further procedures is very, very low indeed.
At PRMA, we use nipple-sparing mastectomy selectively for women who want to preserve as much skin as possible during the mastectomy part of their procedure. Nipple-sparing mastectomy is an extension of the skin-sparing mastectomy techniques. The skin-sparing mastectomy techniques have really revolutionized breast reconstruction in and of themselves because it was able to preserve more skin on the breast, and so that represented a great leap in breast reconstruction. Now, with nipple-sparing techniques, we can essentially preserve all of the skin that's in front of the breast, remove the gland, and get a better cosmetic result. And in a nipple-sparing mastectomy, the incisions are made for the mastectomy adjacent to the nipple in a variety of locations. Sometimes it's underneath the breast at the inframammary fold. Oftentimes it'll be lateral to the nipple, which means toward the outer part of the breast, or going from, let's say, the 6 o'clock position, if you're looking at hands on a clock, down vertically toward the lower mammary fold. The ideal candidate for nipple-sparing mastectomy would be those with early stage cancer, such as stage 1, those who have preventative mastectomies for BRCA mutations or other mutations, and those with stage 0 cancer, such as DCIS, as long as it's sufficient distance away from the nipple to be safe. So one of the concerns that we've had about nipple-sparing mastectomy is that it would increase cancer risk. And in some of the early nipple-sparing mastectomies, indeed, some of the breast tissue was left behind the nipple, and thereby increasing the potential risk. But many studies over the last 5 to 10 years have looked very carefully at groups of patients and found that with the proper mastectomy techniques, it is a very safe and effective procedure. I think it's important to know that the sensation does not return completely, and it rarely does. However, we do want sensation to return because patients oftentimes are more satisfied both with the natural look of the nipple and with the possibility of some sensation returning in the area. Now, there are ways for us to improve the sensation, such as connecting the nerves from the chest wall to, for example, the DIEP flap, if that's the chosen method of reconstruction. And that may be a way to improve sensation to the actual breast, which will go through to the nipple and provide better sensation.
For the revision phase, this usually comes 3 to 6 months after the original foundational phase. After tissue-based reconstruction, after the first phase where we build the foundation, and do a second revision phase, they call it, which is a much easier process, outpatient surgery, that requires usually some modification on the abdomen, maybe a little liposuction, a little trimming of excess skin to make the trunk look better. And then on the breast, if we need to add volume or reduce it or lift it a little bit, we can do that at the same phase. For implant-based reconstructions, the second stage or revision phase would involve removing the expander, revising the pocket if necessary because sometimes it gets tight, and then placing a permanent implant. And many times in that same setting, we'll do fat grafting to help increase the thickness of the skin and subcutaneous tissue to help cover the implant better. So during the second stage or the revision phase, we'll do fat grafting frequently. And that is a process where we'll suction the excess areas of soft tissue or fat. And we suction that not like traditional liposuction where it's done in a more aggressive manner. We have to treat the fat very gently so the fat cells will live. So we suction them on very low suction. We process the fat very gently. We place the fat in the defect, putting it in small amounts so that it will get blood supply, because if it doesn't have blood supply, the fat cells will die. Very often at the revision stage, we'll also do nipple reconstruction, depending on how much work we do on the breast itself. If we're liposuctioning a breast to make it smaller, then normally we postpone the nipple and do that in the office. The nipple is formed using the tissue in the area. We don't do grafts or take tissue from anywhere else. And that tissue is first marked for the spot, and the patient's in front of a mirror. We do the marking. And then we draw a little bow tie design around that spot. And then we just make those incisions, and we go from 2 dimensions where the tissue's like this and actually turn it up and fold it together so it looks exactly like a nipple. And then we let that settle down for 3 months and then tattoo the color. So when you do the nipple reconstruction, that part is just making the nipple. There's no color, there's no areola there. That's been removed during the mastectomy. So after we let the nipple reconstruction heal, then we come back in the office with medical pigments, and you can tattoo the color of the areola and match the color that the patient had before surgery or whatever color she would like.